she went on to have the CT. So there's an arterial and venous phase.
Some active extrav in the ascending colon.
Okay, active extrav ascending colon. Let's see if that's right. So yes, it accumulated on the venous phase here. So this is a nice example of a positive CTA for bleeding. And this woman went on, and so they found this improvisation from a small distal branch of SMA. This is distal SMA bleed. There's this nice radiographics article describing the algorithm for GI bleed. If it's a lower GI bleed, then the patient should undergo CTA as a first line workup. And if we don't see active bleeding, then they can go on to have enterography or EGD. And then if there is, then this patient just goes on to have an IR procedure. And that was curative for this patient. Here, if we see probable GI bleed with no active bleeding seen on CTA, then they would undergo, if upper tract, then EGD. If suspect small bowel, then in capsule endoscopy. And if colon, then colonoscopy. And then if it's upper GI bleed, then these patients just go on to have EGD. In a summary of the workup. And then here's an example of a diverticulum-related bleeding. You can see in arterial and venous phase images, there's a tiny diverticulum indicated by the arrowhead here with some active extrav that increases on the venous phase. So the venous phase is much more sensitive than the arterial phase.
I have some questions.
Yeah.
So, well, one comment, which is that we've had several active, very positive scans here recently, and they went straight to IR. And by the time they got to IR, they weren't bleeding anymore. So I was a little disappointed, and I was asking them, well, would you preemptively embolize because you know, exactly where the bleed is, rather not like a tagged RBC? But they said, definitely not small bowel. They definitely don't like preemptively embolizing small bowel, and even colon, they don't like to do that because they can cause ischemia.
Yeah.
So they really have to see it actively bleeding. And then my other question, the GI fellows were asking me, what is preferred now between CTA and a GI bleeding study? Are they now equivalent, as far as the rate of bleeding?
I don't know if there are more recent studies that show that CTA is improved, although I would imagine that it would be, given that the sensitivity for detecting smaller things is higher now. But I think it's still a preferred study, even though you're referring to the nuclear medicine.
Yeah.
Scan. So in the past, that has had a higher sensitivity, but I think...
Yeah, I have a feeling that CTA has now gotten to the same sensitivity. I just haven't really looked it up. The one advantage for the GI bleeding one is that they can do it over a longer period. So every time the patient bleeds, they can bring them right down. So you could do it over 24 hours.
Yeah.
As opposed to multiple CTs or something like that. But the CT can localize the location much better.
Exactly. And as I think part of it may be bias as being a radiologist, but I think we could see a lot more with the CT scan. And it's actually an easier procedure to do than the nuclear study. So I think overall, I would never recommend a medicine study, even if the data in the past has shown somewhat higher sensitivity. We need some more newer cohorts to decisively determine that it's true.
Would the source of the bleeding also change the impact, the detection, if it's arterial versus a venous ooze? Because I feel maybe it's the venous like oozes are maybe a lot slower, and maybe they can be picked up in cases that are missed by CTAs.
That's true. Although if it's venous bleeding, usually it shouldn't be that problematic.
Mm-hmm.
So whether or not we see it, because even in arterial bleeding, patients often become hemostatic, and
Mm-hmm.
no bleeding is found during therapeutic attempt.
Mm-hmm.
Bleeding, I'm sure, it's even higher rates of no bleeding detection at the therapeutic procedure.
Mm-hmm. What in your case, was there like a reason for the bleeding?
I don't think
Maybe the patient was on like anticoagulation or something.
Yeah, I don't think there was a structural cause. I think this patient was on Coumadin, or
Looks like there's a lot of ticks.
she does have a lot of ticks.
I'm looking at this paper that from 2017 about like GI bleeding from British Journal of Radiology, and it says diverticulosis is the most common cause.
That's right. So if she weren't on that would be the most likely cause. I mean, she does have a lot of ticks, and she also, I think this was an Asian patient. We have a lot of Asian.
Why do they have red-sided ticks?
I tried looking into this, and I don't think we have a reason, except that many papers have described that they do have them. So I actually don't know. But they,
I guess like probably a couple of, like maybe the congenitally, maybe there's something different about the colon, but then the food might be different.
The diet, yeah. It's likely related to the diet, but this is described pretty commonly, and it's actually often a source of diagnostic error. When I've seen several cases where right-sided diverticulitis was mistaken for appendicitis, and usually the more inexperienced radiologists will make that mistake, but it is a common pitfall, and one that every trainee should